Hi everyone, I want to talk to you today about community-acquired pneumonia in children. Community-acquired pneumonia in children. If you can go over all my presentations on pneumonia, like pneumonia in general, aspiration pneumonia, aspiration pneumonitis, hospital-acquired or nosocomial pneumonia, community-acquired pneumonia in adults, pneumonia in neonates, and apostatic pneumonia, then you have less trouble grasping all the concepts here. So you can check them out. Okay, what are the causes of community-acquired pneumonia in children? Strep pneumo is leading, just like the case is with adult community-acquired pneumonia. Mycoplasma pneumonia is possible here. Chlamydia pneumonia, and Chlamydia trachomatis, fungi, Mycobacterium tuberculosis, or viral. What are the clinical features? The clinical features of pneumonia generally is non-specific. It could be fever, apnea, lethargy, poor sucking reflex, vomiting, respiratory distress syndrome, abdominal distension, with or without jaundice, heart is racing, tachycardia, hypotension, or because of possible sepsis, coming down with septic shock, they have hypotension. Viral etiology will present with gradual onsets, and they will not be so toxic compared to bacteria. There could be rashes, like the case will be with measles or varicella. They could be having runny nose or sneezing. If it is bacteria in origin, the presentation will be sudden and it will be very toxic. The fever will be high grade, associated with chills, and when laboratory test is done with complete blood count and white blood cells differential, there will be raised white blood cell count. This individual might be in respiratory distress with flaring of alar nasal tachypnea and use of accessory muscles of respiration, possibility of rashes, and if the child is an older child who could complain accurately, he or she could complain about sore throat. There is possibility of complaining about headache as well in them, and of course with cough. The cough you rule out with color of the sputum and so on and so forth. If it's associated with tuberculosis, the cough is going to be chronic. In other words, it'll be coughing for a long period of time. So we need to rule out possible contact. And in viral situation, there's possibility of other people being affected around. So the individual might not be the only person having the symptoms in the family or wherever the individual lives, like daycare or shelter and so on and so forth. How do we make the diagnosis here? In a child, it will be expedient to do lumbar puncture. Do CSF culture when you get CSF from the lumbar puncture. Do blood culture. Aspirate whatever is along the trachea and do microscopic culture and sensitivity tests. That we can have viral culture with polymerase chain reaction tests. So chest X-ray should not be forgotten because it's very essential. How do we treat? We're going to admit if there's nasal flaring or this individual is toxic. And when you check for peripheral cyanosis and central cyanosis, the child is cyanotic. How about when you monitor the breathing pattern, there's apnea present, or the level of consciousness is altered? Checking the vital signs, you could pick increased heart rate, and there's a hypoxemia. Checking the buccal mucosa, the fontanelle, and everything, you could conclude that this child is dehydrated. Please admit. The mother is complaining that this child is not feeding well, not sucking well if still an infant, or not feeding well if older than that. Grunting, respiration, and dyspnea, retraction, and increased respiratory rate. We're going to admit. I'm going to admit any child with shortness of breath. So it's very likely before you rule all these out, because you are going to admit if you have any one of all this, it's likely we're going to admit this child, because it's not likely that all this will be absent in a child who has come down with serious community acquired pneumonia. So you can get your mind prepared or set that you're going to the hospital and you might be admitted. I mean, your child might be admitted. When the child is admitted, we check the airway for any foreign body or any secretion and treat as is appropriate. Breathing, of course, we've gone over that. Distress, tachypneic, flaring of velar nasal, cyanotic, respiratory is very high. Now, circulatory system dehydrated, the pulse rate, even the BP, check everything, fluid in and out. And you might intubate this individual depending on your judgment. If there's impairment of level of consciousness, it will be wise to intubate. And if you think there's imminent respiratory failure, then without question, you intubate. IV fluid, give oxygen as it may be required, and of course we go for antibiotics here, like ampicillin and gentamicin, because that's going to cover for both gram-positive and gram-negative respectively. Methicillin, resistant Staphylococcus aureus, if that is diagnosed, we go for vancomycin. And in case the diagnosis from microscopic culture and sensitivity is indicating that there's a extended spectrum beta-lactamase here, we go for meropenem. And if the viral culture and polymerase chain reactions are positive for virus, we have supportive treatment only. What are the possible complications here? Necrotizing pneumonia, hematose, lung abscess, empyema, pleural effusion, respiratory failure, or death. That's why it's important to present on time to the good center, no self-medication, present on time, let everything be done on time, and you have your child. Because the child could die from pneumonia. Death is possible. Pleural effusion is possible, on account of which the child will be in hospital for a long period of time. possible we have respiratory failure, lung abscess, hematocele, or necrotizing pneumonia. In conclusion, prompt presentation will lead to prompt intervention. And when you have presented your child promptly, and the good people, the doctors and nurses, intervene promptly, it's very, very likely that we're going to have a good outcome. So many parents have been sued, have been sent to jail for not taking their kids to the hospital on a timely basis. And this is one good example. If presentation is not on time, intervention may be too late. And when that is the case, we may not have a good outcome. Possibly death will happen as well. So kindly present your child, no self-medication. The prompt interventions will be embarked upon, and there's likelihood of having good outcome. So kindly subscribe to my channel so that you can be getting these publications immediately they are made. And I would advise that you go over the previous presentations on different types of pneumonia. Thank you for listening.